Okay. Welcome back, Dr. Theoharides. It's a pleasure to have you. Thank you so much for being here today with us.
Oh my God, it's my real pleasure. Thank you for having me.
Absolutely. So I just want to do a quick intro. Dr. Theoharides is professor at the NSU Institute of Neuro-Immune Medicine and director of the Center of Excellence on Neuroinflammation Research at the Clearwater campus. He was professor of pharmacology and internal and director of molecular immunopharmacology and drug discovery at Tufts School of Medicine for 39 years and remains as adjunct professor there. Dr. Theoharides is in the world's top 2% of most cited authors and is the top-rated expert on mast cells, which we will dive into a bit today. So thank you so much again for being here. We're going to talk about the complexities of interstitial cystitis, bladder pain syndrome, which is a chronic pelvic pain condition that millions suffer with. We will explore the nuances of this condition, its diagnosis, challenges that patients face.
Yes.
So let's dive in, and maybe we'll just start off with how you would define interstitial cystitis / bladder pain syndrome.
Okay, so clinically, we basically define it by someone having symptoms that are very consistent with what might have been a urinary tract infection, but the cultures turn out to be negative, and or urologists might give them different types of antibiotics for 2 weeks at a time over, again, a 2-month period, and nothing got better. So that's basically the clinical diagnosis. At times it might be confusing because, as we all know, we call it interstitial cystitis / bladder pain syndrome or pelvic pain syndrome, if you wish. But not everybody has the same symptoms. So many patients may have a lot of frequency in getting up in the middle of the night and a lot of pressure in the lower part of the abdomen, but not necessarily pain. It appears that fewer than 50% maybe have pain as the immediate symptom rather than frequency. But again, it varies depending on the provider and the type of patient. All I'm trying to say is, for those who listen to us, you don't necessarily have to have pain to have this condition, and you do not necessarily have to go to the bathroom, every 30 minutes to have this condition, because you can have symptoms sort of in between. Now, many years ago, when I participated in a number of clinical trials funded by the National Institute of Health, the NIH had set up different criteria for selecting patients to participate in the clinical trials. And the main criterion, which doesn't hold really very much anymore, was to do cystoscopy under spinal or general anesthesia, fill up the bladder with, we call it hydrodistension, but it's not just water, it's normal saline. And as the bladder basically sort of enlarges, you see microbleeds on the lining of the bladder, which are called either petechiae or glomerulations, even though I'm not quite sure what glomerulations actually means. We don't do that most of the time anymore because it is invasive, and most my colleagues will go with just the clinical presentation. However, if there is a lot of pain, I would agree with my colleagues that it would be worth doing this procedure, because that's the only way you might identify ulcers that are called Hanner's ulcers, which could be very painful and may actually be amenable to burning with a laser, which can only be done under this procedure. So again, if there's some extreme cases, whatever extreme means for the individual, that cystoscopy would be necessary. However, I would take issue with any urologist who have said to any patient, and there have been a number of them, by doing cystoscopy in the office and looking in the bladder, that you don't have interstitial cystitis. You cannot identify that by just doing cystoscopy in the office unless you distend the bladder.
Right.
So,
yeah, and it can be a very uncomfortable procedure, especially post
I would imagine
procedure. For many patients, a lot of pain and discomfort can be experienced. So I often, tell people now they're debating whether they're going to do a cystoscopy. with hydrodistension, and I say, if you don't need it, don't bother.
Right.
And then obviously make sure you have the general anesthetic, because when they just do a local, it's not enough for
It's
most
not going to be
ICU.
enough. Correct. Now, for some patients, it may be important because they need to know, is it really interstitial cystitis? And if that procedure will provide that additional evidence, then it might be worth it for that patient. And another reason why it would be important is because, unfortunately, many urologists still do not believe this disease exists. I'm sorry to say for my colleagues, but they don't. And as an indication of firsthand experience, this time last year, I organized a symposium conference on interstitial cystitis at Clearwater, Florida. And we had 3 incredible speakers, including Dr. Whitmore and Dr. Moldwin, et cetera. And I had personally emailed every urologist in Florida, and I had sent a package by regular mail to every urologist in Florida. Only one actually showed up. So I can't imagine why they would not have been interested. It was free anyhow, and it was in Florida. So I can only imagine they just don't want to bother.
It's a very strange response to IC.
Very, very, very strange.
Very, very odd. And I wonder if it's just because they don't know what to do with the patients.
Most likely, yes. And these patients, for good reason, are very well read and demanding to know what is going on, as they should. And, which brings me a little closer to what we are doing these days, they are complex disease patients, not complex patients necessarily, in the sense that I often find that about 60% of them may have either allergic problems or sensitivity to foods, about which we can talk about. Others have fibromyalgia. Many of them have migraine headaches. So therefore, for a urologist, all the other conditions seem to be complicated, as they are. So we really need physicians or centers that can look at patients a little more as a whole, not holistic, as a whole, because I think that many of the underlying pathologic processes are actually fairly common denominator for the other comorbidities that I mentioned. And I think if we address one effectively, I think some of the others will actually subside to some extent. And we can get back to this a little later.
Yeah. Well, let's talk about food. How do you sort of address that topic?
Okay. So I already said that about 60% of them, of patients with interstitial cystitis, seem to have allergic-like problems. I call it sometimes allergic diathesis because they might not be aware of it, or they might not have been tested for it, or if they were tested only for allergies. And let me explain what I mean. So allergy is a broad umbrella. If you're truly allergic, then one particular immunoglobulin called immunoglobulin E or IgE is involved. It sits on the surface of specialized immune cells called the mast cells, M-A-S-T, and when the antigen or allergen to which the antibody was made hits now the surface and bridges 2 or more of this antibody sitting there, the mast cell explodes like a hand grenade, releasing all kinds of molecules, as many as 100 different molecules, of which we mostly deal with histamine, and we have antihistamines. Okay? However, the mast cells can be triggered by many other triggers, so that if the trigger is immunoglobulin E and antigen, sometimes we call it atopy or atopic disease. So that's limited only to IgE. If there are other things, it becomes allergy. And now we have a lot of evidence that the mast cells can be triggered by substances that we never considered in the past, such as the first hormone released under stress, about which we had published many papers relating to the bladder, called CRH, or corticotropin releasing hormone, where the mast cell does not explode, but it releases molecules and we will never be able to see them at typical light microscopy. And then you have this now new umbrella. We call it mast cell activation disorders, where the mast cell can be activated by anything, and we might not know as yet which is the trigger, so we call it mast cell activation disorder. And then finally, we have histamine intolerance. That's different because histamine can come from mast cells, as well as some circulating cells in the blood called basophils, but it comes from foods. For instance, cheese, tomato, avocado, spinach, sardines, spices have lots of histamine. And our body breaks down histamine by using two different enzymes. The best well-known enzyme is known as DAO, which stands for diamine oxidase. And now we can do gene analysis for patients and know if their enzymes are working properly or not. But if they have problems with this enzyme, we call it mutations or polymorphisms, then you cannot break down histamine, in which case you respond to histamine even without the mast cells being involved at all. So in histamine intolerance, because the enzyme breaks down histamine, the histamine might be acting not only in your skin, but in your gut, also in your bladder. For instance, a paper was published in the journal Nature about a year ago with an editorial in the New England Journal of Medicine, where they showed very convincingly that histamine being released in the gut, they only studied the gut in that paper, sensitizes sensory nerve endings in the gut, and that senses basically pain in the brain, even though there's no actually inflammation, just the histamine. So you can imagine the same thing can be happening in the bladder, where there are lots of mast cells, and both we and others have published on them. So histamine released will sensitize the sensory nerve endings, and that will send basically the message of pain, even though there might not be an ulcer or inflammation, which in certain cases, of course, they are. But I'm just saying, even histamine alone can do that. And that's why, Dr. Moldwin in New York was very well known in the area of interstitial cystitis. Over the last 3 years, was studying with various questionnaires the possible effect of foods on interstitial cystitis. And he published a paper, and he gave a lecture last year here in Florida, that as many as 70% of patients with interstitial cystitis reported sensitivities to various foods, even though neither they nor he knew exactly what it was in the foods that caused the problem. But the foods that they listed as foods that bother them are the foods that I already alluded to contain a lot of histamine. Okay? So I am a proponent of, number one, asking patients, tell me if any of your symptoms, I don't try to specify pain or frequency so that I'm not actually leading the patient along. Just tell me any of your symptoms might be worsened by any food you eat. That's number one question. If there's any indication or suspicion, then I will ask them to do a food intolerance test. We can do both. We can do a food allergy test, except that in food allergy, I have to specify which particular food substances I'm checking for. Which you cannot just do it for everything. So I may say, I want to check for gluten, for casein, for whatever. But about 50% of the patients that have sensitivities turn out to be negative on food allergy, because that tests the presence of immunoglobulin E against an allergen. In food intolerance, it is IgG subclass 4 that is involved. So I will therefore ask for a total immunoglobulin E, total immunoglobulin G4, and send for a food intolerance test, which will test for about 250 foods. But there's a caveat. If you eat something every day, it turns out to be false positive. So I ask families, patients, if possible, for about 3 days before the blood draw, to eat just boiled chicken and rice, the old, grandmother's recipe. So no preservatives, no spices in it, just plain boiled I've never seen anybody having intolerance to that. And then I believe the results when they come out. But if we eliminate those foods, and or if we were to add an antihistamine to block at least the effect of histamine, or add the DAO supplement, which exists, we can buy them, we give it 50 minutes before a meal. All those three, avoiding the foods, adding the DAO before meals, and adding an antihistamine, will certainly help with a lot of the symptoms. And then I always say, let's see what is left so we can address those. It might be the bladder lining, it might be inflammation, but let's deal with the simple stuff first to see how well we can do before we start going heavy duty with other approaches.
Okay. Do you see a lot of IC patients have other pelvic health conditions?
I personally don't, because first of all, I don't see patients anymore,
right,
as you probably know, but it doesn't
Yeah.
matter. I see them with other colleagues as a consultant. But
Yeah.
here in Florida, we do not have a clinic for interstitial cystitis. So we don't really see. But because of the lectures I give, like your invitation here, a lot of patients will reach out for help, and I will try to give them at least some advice. And because of that, I have now, as of about a month ago, created a very simple website, which is drtheoharides.com, where I indicate helpful information under certain categories, one of which is bladder health. And I also have a lot of Q&As answered. As they come in from patients, I answer them and then I posted them. So that way, a lot of patients or interested individuals can find some answers to. So from those answers and the questions, I found out three things. Number one, that a lot of these, primarily ladies, do have very frequent yeast infections. Now, we all know that yeast infections are quite common, as they shouldn't be, but they are in females, but not if they're really common. In other words, if you're getting it with every sort of cycle or 2-3 times a month, that's not normal at all. Nothing is normal, but that's really way too common. So I started thinking, what might that mean, number one? Number two, many ladies also report that they have symptoms of what is called either vaginitis or vaginosis. There might be either inflammation with or without an infection in the vagina. And many times these things are not actually investigated any further. Usually a gynecologist will say, take an antibiotic and sort of hope for the best. And the last part is that, as we know, as many as 30% of the women with interstitial cystitis have symptoms of what is called vulvodynia, meaning a lot of pain when you touch the vulvar area. And sometimes it's called vestibulitis, where there might be inflammation in that area. So I started wondering, could there be a connection with all of this? Because obviously the opening of the bladder and the vagina are quite close. In some ladies, it's even closer anatomically than others. So, a yeast infection could spread from, for instance, the urethra to the vagina, vice versa, so to speak. And if there is then a local inflammation, that might contribute to the vulvodynia. So one of the questions we asked is there any chance that mold or fungi or the toxins that they release, which are called mycotoxins, might actually be stimulating immune cells directly? Because we usually deal with such infections by giving, drugs like nystatin, monistat, things of that sort, to just kill the yeast. But we don't worry about what has happened in the interim if the yeast was releasing molecules. So we decided to use one of the most common toxins from yeast called ochratoxin A, which is, by the way, found not only in yeast that might grow in the body or on our tiles, but also in foods. Many, especially organic foods, do contain yeast on the surface, and you cannot get rid of it by just washing it. You really have to use either soap water or just peel the fruit or the vegetables or boil them, of course. So we used ochratoxin, and stimulated human cultured mast cells that are involved, as I said earlier, in allergies and intolerance.
Mhm.
And the mast cells were stimulated to release not only histamine, but numerous pro-inflammatory molecules. So we have direct evidence now that that is the case. No one has studied that in interstitial cystitis patients that I know. However, a colleague of mine, Dr. Irma Ray, measured the presence of mycotoxins by sending them out to a laboratory.
Mhm.
It used to be called Great Plains Laboratory. Now it's called Mosaic Diagnostics. And there might be others that do that. In patients with chronic fatigue syndrome, many of which do have symptoms of interstitial cystitis, but because the chronic fatigue is so much worse in their mind, they sort of downplayed what happens kind of in the bladder of that area. So most of those patients with chronic fatigue syndrome did have high levels of ochratoxin A in their urine. So one of the things that I would love to do with, of course, one of my colleagues that does see patients, is to get some urine, or they can send it themselves out to one of the laboratories that I mentioned to check if, in fact, there are mycotoxins in the urine. That might be at least one environmental trigger potentially for interstitial cystitis. We kept on looking for internal, innate triggers, which of course they may be there, but I think there's a combination of outside and inside triggers that eventually lead to the problems we're dealing with.
Mhm. What would Elmeron has its issues, as we know, retinal maculopathy correlation. Is there any other drug on the market that's being prescribed for patients with IC, or are they working on anything exclusively for the condition?
So there's no drug in the market, at least that I know of. I
Mhm.
know there's a clinical trial going on because the US Interstitial Cystitis has been sending messages for people to participate. I
Mhm.
don't know much about the drug, so I cannot really comment on it.
Mhm.
But there are other ways that we might be able to help. Um, so let's just think about what might be happening in the bladder. So you have the bladder wall, and then you have the bladder lining. Obviously, the bladder lining is the first thing that comes in contact with the urine. So if there is anything that is likely to damage the bladder lining that exists in the urine, will cause problems. So therefore, we have to preserve the integrity of the mucosa or the bladder lining as much as possible. That's number one.
Mhm.
We'll talk about what that means. Number two, there might be inflammation going on either in the mucosa or in the muscle that we don't know why. And if there is inflammation, we have to deal with the inflammation and reduce it, as would be the case for any other tissue or organ in the body.
Mhm.
Then we have the sensory nerves that shoot the pain signals to the brain. Well, they don't do it for no reason. So obviously they got activated at some point and either continue to be activated if there's ongoing damage, inflammation, etc., or they went into a state of what we call phantom pain, where the trigger is not there anymore, but the nerves think that there is, and they keep on shooting messages up. So we will have to address all of those. So if we start with the possibility that histamine activates sensory nerves, as we discussed, then we have to reduce the histamine for obvious reasons. How do we do that? We block the mast cells that release it. We help avoid the foods or other substances that do have histamine, and we help break it down. And we should do all three. So we should basically let patients know this is the list of foods that contain a lot of histamine. Try to avoid them, at least until you have yourself tested, in which case you will know or not know. You can get the diamine oxidase supplement. There are many companies that sell it. There's one caveat that it comes only from pork, so some ethnic and religious groups might not be able to do pork. There's only one company that gets it from bean sprouts. That's called Natur, without the E, nature without the E, Natur DAO. You can get that. And now there's a company with whom we are working with because we will try to have a product in the market that will be actually recombinantly made. in tissue culture, in which case there are not going to be any food substance or animal products, etc. That might be ready by Christmas time.
Okay.
So that deals with histamine, but what if there are other inflammatory molecules being released? Well, we don't have anti-inflammatory drugs. We have either cortisone, in some cases we will use it, or we have the so-called non-steroidal anti-inflammatory drugs, such as naproxen, ibuprofen, Motrin, or whatever you. But many people are irritated by those, and if you have open wound, that's not going to help very much. It will be very irritating. So we kind of try to avoid those unless we absolutely have to. Sometimes we can find out if we can use them by measuring in the urine the molecules that are blocked by these drugs called prostaglandins. So if prostaglandin is way high, then I'll bite the bullet and say, well, I've got to stop it somehow, in which case we'll start with small amounts and see how we go. Mm-hmm. How do we block the mast cells? There are no inhibitors of mast cells in the market. The only drug that is available is called cromolyn, but is absorbed less than 5% from the intestine. So it will never get into the bladder. And in fact, if you push it too much, you start getting diarrhea. So it's not an easy drug to use. We, as you know, have been studying a certain class of molecules called flavonoids for almost 30 years. And we, 20 years ago, when I didn't know any more that I will tell you about, we chose one that seemed to be the best flavonoid to inhibit the mast cells, which was called quercetin or quercetin. Mm-hmm. So we took quercetin to block the mast cells, and we took the two ingredients that make up the protective lining of the bladder, which is hyaluronate and chondroitin. Those are damaged first, and then molecules can go farther in and damage the mucosa of the bladder. So you've got sort of the lining here and then the mucosa. So we're replenishing basically the hyaluronate and the chondroitin. And because these molecules are not absorbed very efficiently from the gut, we mix them up with olive pomace oil. The French call it olive fruit oil, sounds a little better. And we made the Cystoprotect with a K that was made basically 20 years ago, and it's still available. So that will block at least the mast cells from releasing both histamine and other inflammatory molecules. Plus, you will provide the hyaluronate and the chondroitin that make up the protective lining of the bladder. Since then, we have tested other flavonoids, and it turns out that another flavonoid called luteolin, which is 90% similar to quercetin, is even better to inhibit the mast cells and inhibit inflammation. And in fact, just this month, we published a paper in the International Archives of Allergy and Immunology, where we pre-treated mast cells with the exact amount of either the drug that I mentioned before, cromolyn, or luteolin, for just 10 minutes. And then we tested 10 different molecules that were released from mast cells that were stimulated by an allergic trigger, including histamine. Luteolin was 3 times better than the otherwise existing drug cromolyn in inhibiting the mast cells. So now there's no question that it is better. So therefore, if I suspect that there are mast cell activation problems or allergy problems or sensitivity problems, I now recommend the Cystoprotect together with pure LUT. That is the only product out there that has pharmaceutical grade luteolin. It's 99% pure luteolin in, again, olive pomace oil to increase the absorption.
Wow.
So going over it is avoid the foods or do the food intolerant test and then avoid them. Get the Cystoprotect for the reasons that I mentioned, then get the pure LUT, which is pure luteolin, on board, because together with quercetin, they have better anti-inflammatory and better mast cell inhibition effects. And if you Google it, you will, or if you go to PubMed.com, you can find the publication, or if you would like, I can send you the PDF of the publication to share with.
Yeah, I'll put it in the comments for sure so that people can access it easily.
Right.
That'd be great. No, I mean, people have just the number of people who've had such a wonderful response from Cystoprotec is it's incredible.
Thank you for saying so, and I'm glad they do. But again, without knowing the specifics of an individual patient, we might be missing other ways of helping them. And that's why I mentioned, and I will re-mention it again, that it's very important to make sure that there are no other sensitivities that might be contributing all the time. Because otherwise, we're spinning our wheels. We're giving Cystoprotec to protect the bladder, but we allow the triggers to keep on damaging the bladder.
Right.
So that's why it's so important to avoid those substances, as well as add now the pure loot on top of it to have actually even better effect.
So will there be a product containing this in the future? Like the lutein? Will it be added into?
Well, I don't want to add it to the Cystoprotec. It's a very good question, and I'll mention something else in a second. Only because this is nature for all of us. If we're happy with a product, we worry what will happen if we add something else. Will I be sensitive to luteolin? Will I tolerate luteolin? Even though, as I said, it's 99% similar to quercetin. And I don't want to put those individuals who have already gotten a lot of benefit and continue to get benefit in the predicament to start worrying about it. So what we're trying to do now, and maybe you could send a questionnaire to everybody that follows you, to ask for a good new name for a product for the bladder. If anybody comes up with a good one, we'll give them special deals. We're going to come up with a product that will have the luteolin, just like you asked, but it will have 3 additional ingredients, 2 of which are fairly well-known natural ingredients to heal wounds, whether it's ulcers, whether it's microbleeds or whatever, and 1, again, natural ingredient that's very well-known to desensitize sensory nerve endings. So those will be additional, basically, to any benefit the Cystoprotec is providing, because it now attacks, as I said, the wound part and the sensitivity to the pain part or the sensory nerves. And I think that will be a tremendous addition to the Cystoprotec. We hope to have it available by late fall this year.
Oh, amazing.
So
yeah, well, thank you so much. This has been incredible. You have so much knowledge, and it's so great that you share it with all of us. And so we thank you so much.
But we do need to collaborate. So I do need to collaborate with my urologist colleagues who do see the patients, because we do need biological fluids, especially urine. And the reason is, and maybe I'll finish with that, is that we're trying to recreate, if you wish, the local milieu of what happens in the bladder, as it might happen in the skin for other conditions or in the brain for other conditions. We all over the years have been struggling with surrogate models, and we don't have good models for diseases in general. As you know, for interstitial cystitis, at least we have the feline model, the cats.
Yeah.
But you can't do that many things, with the whole animal. So we are trying to create. We will be using a certain instrument, which is a sort of self-contained incubator. In the center well, we actually place sensory neurons, and we record basically their activity. So if there's no trigger, hopefully they'll be just quiet, doing their thing. And then there will be satellite wells. And in the satellite wells, you can put other cell types of interest. So we can put bladder lining cells, mucosal cells. We can put immune cells. We can put any other cell, or we can put some other cell type that we never thought of it until now that might participate. You allow them about 3 days, and what happens is the neurons crawl and make connections with the other cells through microfluidic channels, and the fluid that bathes them allowed them to communicate with anything they might be releasing. So now we establish a baseline. That's my hope. So
Yeah.
now I want to trigger each satellite cell differently with its own specific trigger and see if they're triggered, do they affect the neurons? I might not know what is being released, but if the neurons are affected and they start firing like crazy, then I know something is being released from those cell types. Now, the triggers for the cell types might be chemicals, or there might be mycotoxins, or there might be something else. The beauty of this is, first of all, you try to create more of a local environment rather than using single isolated cells, number one. Number two, you can now take the fluid that was being released that stimulates the neurons and analyze it for what is being released. And you can take the leftover cells in the satellite wells and study those by what is called RNA sequencing. In other words, we can see which genes got activated. And if we know which genes got activated, we now know what is the product that is being released. Once we do all of that, you can now start pre-treating this surrogate model with either drugs or natural molecules to see what best blocks the outcome, which is firing of the sensory neurons that sensitizes and causes pain. So we're hoping that we'll have that up and running by the end of the fall. And it is that time that I would want to reach out to my urology colleagues to see, can I get some urine and add it to this to see, does that stimulate? And if it stimulates, what is it in the urine that stimulates, et cetera.
You have to have more people like you doing this kind of thank you so much for doing all this research. It's amazing.
Thank you for saying so.
You're really, taking us to a whole new level, and hopefully we'll, IC patients will see some really great.
I am very hopeful that in spite of the fact that for the last 30 years, we didn't really do that much better, the next 5 years will be phenomenal. I really feel so.
Let's hope. Yeah.
So let's all help each other, help you.
Yeah. I know with mRNA, the vaccines, they have been doing a lot with mRNA. Is there anything would you think IC to benefit from a vaccine or anything?
Well, yes and no. First of all, let me say that in general, vaccines are helpful, even though I'll qualify the statement in a second. Number two, vaccines are helpful when we know a specific, most of the time it's an organism that causes the problem. Here we don't know that. We don't have a particular organism that causes the problem. Therefore, it's very difficult to consider what a vaccine would be like.
Right.
So from that point of view, in the strictest definition of a vaccine, that's a problem. Yeah. However, if we were to find out that molecule X, that might be our own molecule, is causing the problem, then yes, we might be able to desensitize our own selves against that particular component. Okay. Now, the qualification that I wanted to make about COVID vaccines is as follows. The vaccines have helped blocking the coronavirus spike protein from binding to a receptor, going inside the cells, multiplying and killing individuals. Right. And in fact, we don't have that many deaths, thank God, anymore. However, I invoked the possibility about 2 years ago, and now have published evidence, that in certain tissues, especially the brain, I don't know about the bladder yet, it is not the actual virus that is a problem, but it's its spike protein. The spike protein can be shed from the virus, and of course, it is made by vaccines, because we make the body to make the spike protein so that it will create antibodies against the spike protein on its own. So we said, could the spike protein be lingering on for much longer? Because we are very interested in long COVID, brain fog, paresthesias, peripheral neuropathy, etc. So 2 colleagues, one group in the States and one group in London, showed that the spike protein can stay on to at least 2 years after the original infection. So that's number one. Then others tried to find it as to where it is, and they couldn't quite find it. So now we're talking about reservoirs where it's hibernating. And maybe in the brain, it might be in the gut, maybe in the bladder. So what we did is we said, okay, if in fact inflammation is the cause of many problems, can we show if the spike protein could cause inflammation? So we obtained recombinant, meaning pure spike protein. We edited on the mast cells, and the mast cells got stimulated to release inflammatory molecules. Just the spike protein, not the virus. That was finding number one, which this is published already. Then we said, is it through the receptor to which the coronavirus binds, which is called ACE2, ACE2 receptor? Or could it be through receptors that are triggered by what we call damage association patterns, we call them. In other words, molecules that are released from pathogens, but they're not the actual pathogen. And these are called toll-like receptors, TLRs. Okay? So how do we show that? We incubated the mast cells sequentially with different antibodies that block different TLR receptors. And we showed, and we published, that only when we blocked the TLR4 receptor, we blocked the inflammatory response. Then we decided to do the same thing using the microglia, which are the immune cells in the brain, because the brain doesn't have circulating immune cells. We showed exactly the same thing. So my worry is that such infections, and it might not be just the coronavirus, it might be EBV after mononucleosis, for instance. We might not have the infection anymore, but we may have certain molecules from the original pathogen that linger on, that trigger mast cells and microglia, causing problems. Therefore, I would love to be able, which of course we will do with what I just described, to take, for instance, bladder lining cells and add the spike protein or add the EBV protein and see if we can actually trigger a response. And I think that's what we will find might be the reason for many autoimmune diseases. We'll be looking for the actual pathogen to be present, and we'll be missing the fact that material shed from the pathogens might be staying on and not clear from the body at all.
Right. Yeah.
So our approach to what we should be looking for and what to inhibit is changing. The good part is that luteolin that I mentioned earlier blocks both the mast cells and the microglia 100% from being stimulated either by the spike protein or by the mycotoxin that I mentioned earlier. So even though we were using the luteolin and the quercetin, earlier for other reasons, now it turns out that we might be getting additional benefit from these molecules, except that you have to push the amount that you give a little higher.
Right.
So I used to say, for instance, 2 capsules a day, one in the morning, one the evening or late afternoon. In order to get these additional benefits, you definitely have to go 2 and 2. 2 in the morning, 2 in the evening. It's not enough otherwise.
Okay. Good to know. All right, Dr. Theo. Well, thank you again, and we will hopefully have another chat in the very near future.
I appreciate it, and I really commend you for all your efforts.
Thank you so much.
All right.
Have a good one.
Bye.